Hello and good morning. Today's class is going to be in measles. Measles is a highly contagious viral disease which primarily occurs in children, but it can occur at any age and especially in the unvaccinated individuals. This is common. So today I'll talk on the measles clinical features, pathogenesis, and the different phases, and complication part I'll discuss in another class. So measles is also known as rubella, and in the picture you can see this is a rash of measles. It is common all over the world, so it can be endemic in different places. In measles there is only one serotype, and man is the only reservoir. There is no animal reservoir in measles. Now come to the agents. It is caused by measles virus, and this is a RNA virus belonging to paramyxovirus family, and then the genus morbillivirus. The transmission of measles is one by direct contact. So 90% cases can occur with the direct contact. So anyone who comes in contact with the child having a measles, they can have measles. Another is it occurs through the droplet spread. So that is through the nasopharyngeal secretion. And many times, and this is not so common, it can occur through lacrimal or blood secretions also. But this is not very common. Host factor. The common age is 6 months to 3 years. It can occur even up to 10 years. It occurs with equal frequency in both sexes, and it is more commonly seen in the malnourished children who are immunologically compromised. And virgin population, that means population who is never exposed to measles virus, the susceptibility is 100%. The immunity after you get measles is lifelong. So one time you have measles in life, you get a lifelong immunity. Second time you will not get measles. And immunity in infants, they get maternal antibody till 4 to 6 months of age. So till 4 to 6 months of age, these infants, they escape the infection because they are protected by the maternal antibody. The environmental factors. It's very commonly seen during winter and spring season, and in the overcrowding areas it is more commonly seen because of the high contacts. The incubation period for measles is 10 to 12 days, and the peak is the 7 days. And period of infectivity is 4 days before and 5 days after the rash. So it is very highly contagious, so you should be strictly isolating a child who's having measles. Now come to pathogenesis. The measles virus first invades the respiratory epithelium or skin or the conjunctiva. From there is a local multiplication, and then the virus enters the blood within 2 to 3 days. So this condition is known as primary viremia. During primary viremia, the sign symptoms of measles is not yet observed. Then this virus invades the reticuloendothelial system, that means liver, spleen, lymph node, bone marrow, all these parts. Then after that again this virus comes to the bloodstream after 5 to 7 days, and this condition is known as secondary viremia. So this is the time when the child gets all the systemic symptoms. So the system it is affecting more is respiratory system, which may lead to pneumonitis. It affects the eyes, leading to conjunctivitis, which is the initial symptom of measles. It affects the skin, so you get the skin rash, and then it also affects the oral mucosa. In the initial phase you get a Koplik spots. So this chart is showing you, this graph shows the progression of the measles. So initially there is an incubation period. After that Koplik spot occurs just before the appearance of the rash, when the disease is manifested, and then the antibody titer is seen in this way. The clinical feature is divided into 4 phases. Number 1, prodromal phase, also known as pre-eruptive phase or catarrhal phase. Number 2 is enanthematous phase. Number 3 is exanthematous phase, and number 4 is the recovery phase. In the prodromal phase, there is low-grade fever which persists for 1 week, and this phase is prominently lasting for 3 to 5 days. And then this is followed by 3 symptoms. You can remember 3 C's. So that means 1 C stands for dry cough. Second is coryza. The child has coryza and severe runny nose is there. And then there might be conjunctivitis. So these 3 C's are usually present along with the fever during the prodromal phase of measles. Then comes the enanthematous phase. This phase is pathognomic of measles. In this phase, Koplik spots appear. So Koplik spot comes from the person's name Koplik, who discovered it who described it in 1896. This Koplik spot is small grains of sand on red base, sand-like structures occurring over the red base. If you see the picture, it is like that. It appears 24 hours before the appearance of the rash and then ends by 2nd day of rash. And the site where it occurs is opposite the lower molars, but it can also appear in the lips, buccal mucosa, hard and soft palate, conjunctiva, gums and vagina. But the most common site is opposite the lower molar. So you need to observe the opposite the lower molars. You can see these spots. So in the picture you can see small sand-like grains in the red background. So this is another Koplik spot seen in the palate, and this is in the buccal mucosa. Then comes the exanthematous phase. This rash of measles occurs 4 days after the fever. The rash is generalized maculopapular erythematous, and then sometimes there might be lymphadenopathy also. So in the exanthematous phase, the rash, so this description of rash is very important for your diagnosis, and even for the exams this is important. So rash is faint, macules, blanches on pressure initially, then it becomes maculopapular and confluent. And the distribution is, first it appears behind the ears, then forehead, then face and neck, and then spreads to trunk, extremities, and then involves also the palms and soles. So this is very important for the diagnosis of measles. Then rash disappears in the same progression. That means by the time the rash appears in the body, the face rash disappears. So in 2 to 3 days the rash starts disappearing. So as it had appeared behind the ear, forehead, so similarly behind the ear first it disappears, then forehead it disappears, so accordingly then it slowly goes down, and trunk and extremities it disappears. And then the rash leaves behind a browny discoloration which gradually heals by time. So this is in this picture you can see the confluent rash of measles. So these are blanching rash. These are also rash of measles. Now we'll discuss some atypical phases of measles. Number 1 is modified measles. This is observed in partially immune individuals. So in this, symptoms will be milder and duration of illness is also short. Rash may be absent, but you get the other features. Another is hemorrhagic measles. This is a very severe type of measles which leads to mortality also. So this is a severe form where the child has a very high grade fever. There is altered sensorium. Child may have convulsions, delirium, stupor and coma. And then child may bleed from mouth, nose and then GI tract. And then mortality in this case is very, very high. So this is a rash of hemorrhagic measles. It is more like a petechial rash than the confluent maculopapular rash. And there is another atypical measles, which is very rare. So atypical measles usually occurs in recipients of killed measles virus vaccine who have later contacted with the wild measles virus. But the measles virus which is coming under the scheduled vaccination is a live vaccine. So those people who get killed measles virus, so this is which is very rare, they only get this type of measles if they are coming in contact with the wild measles virus. So here typical prodromal symptoms are not present except for fever. So you get confused with the other fever with rash or other viral exanthems. So here you get a severe headache, there is abdominal pain, vomiting, myalgia, pneumonia with effusion. There might be atypical exanthem. That means rash will first appear on the palms and soles instead of behind the ear and forehead. Then it goes to the wrist, then spreads to the trunk. The rash may become vesicular or pustular, and then Koplik spot is also very rare. So if the atypical measles occur, then it is very confusing with the other viral exanthems. These are the different atypical rashes of measles. So it can be petechial in a hemorrhagic rash, ecchymosis also in a hemorrhagic rash, urticarial, faint macules may be there if the rash is modified measles, and scarlatiniform rash, hemorrhagic rash. So these are the different rashes which can occur in measles. Then last phase is recovery phase. So here the patient starts improving and then the rash disappears after 5 days. In a sequence it had appeared. So gradually behind the ear it will disappear, then forehead, then face, then neck, then body, trunk, and then the extremities. So that way the rash will disappear and then the general well-being of the patient will also improve. Now come to the differential diagnosis. So all the fever with rash can be differential diagnosis for measles. So any viral exanthem, Kawasaki disease where rash is seen, erythema infectiosum, this is also known as fifth disease, and in infectious mononucleosis, roseola infantum, chickenpox, scarlet fever, rubella, dengue fever. So all these are fever with rash. Now come to diagnosis of measles. It is totally based on the clinical features. So many setups where you do not have facilities, no investigation is required. Only by seeing the rash and the distribution of rash you can say this is measles, except if the measles is modified or if it is a different type of measles. Otherwise it is very easy to diagnose measles. In the lab, if the facilities are there, you can do the complete blood count, which will show you leukopenia with relative lymphocytosis, and there might be absolute neutropenia sometimes. Serological test, if available, will be helpful, especially for the atypical type of measles. So you can do measles specific IgM antibody, which is present or positive up to 1 month after the illness, and measles specific IgG antibody titer you can see. If it is 4-fold rising, then only it is diagnostic. Otherwise many times it reflects the maternal antibody. And then isolation of the virus from urine or nasopharyngeal aspirates is the gold standard, but this facility is not available everywhere. Now come to the treatment. Treatment is symptomatic and supportive. So isolation of the patient for 1 week is very essential because it is very contagious disease. Then take care of the fluids and food. So plenty of oral fluids and then good nutrition should be given, as the child is immunocompromised when the child has measles. And then control the fever by antipyretics, especially you can give paracetamol. And vitamin A you need to give 2 doses for consecutive 2 days. And then if there is eye sign of vitamin A deficiency, you need to give 1 extra dose at 4 weeks after the second dose. Then you manage the complications. Complication we'll discuss in next class. So this is the dose for vitamin A. 0 to 6 months, 50,000 international unit. day 1, day 2. 6 month to 11 month, 1 lakh unit, day 1, day 2. And then more than 1 year, 2 lakh unit, day 1, day 2. You have to give the vitamin A. And then third dose only if required. Okay, thank you. Next class I'll discuss the complications of measles virus. If you find my class helpful, please subscribe, like and share. Thank you.